This week on the BackTable Podcast.
I think if you're really using this technology, the mechanical technology, and even now with aspiration, I've always been of the mindset of starting more proximal and working distally, which, I think in the interventional cardiology training was always you start distal and work prox. This is a situation where, I want to use that obstructed outflow kind of as my safeguard as I debulk what's ahead of me. I don't want to just plow through that street and then just try to deal with the aftermath of things showering. I want to just start proximally, debulk, thrombus, take another interval picture, try to decide, run your IVUS down again, see where your level of, open vascular structure is now, and then just keep working. So prox to distal.
Ladies and gentlemen, welcome to the BackTable Podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is backtable.com. Very easy to remember. Subscribe to the show, leave us a review, or reach out to us on social media. Now, a quick word from our sponsor.
When you need to restore flow in an ischemic limb, there's no time to lose. You need the Pounce Thrombectomy System. The Pounce system from Surmodics is a purpose-built percutaneous device for removing thrombus and embolus in the peripheral vasculature. No capital equipment or aspiration needed, just grab, go, and restore flow. It's simple. With the Pounce system, you place the basket wire distal to the clot, place the collection funnel proximal to the clot, pull back to collect the clot in the funnel, and retract the system through your guide sheath. The secret sauce? The Pounce funnel is designed to macerate and dehydrate the clot, allowing you to remove even large amounts of material through a 7 French sheath. Visit pouncesystem.com to learn how physicians have used the device to accelerate on-table flow restoration while reducing use of thrombolytics. Pounce Thrombectomy. Strike quickly to capture and remove clot. Now, back to the episode.
Our topic today is acute limb ischemia, and specifically we're going to be talking about using mechanical thrombectomy to treat this patient population. Our guest today is Dr. Dean Ferrera. Dean is an interventional cardiologist working in Indiana. Dean, welcome to the show.
Thank you so much. Thanks for having me, Chris.
Dean, just as an icebreaker, will you tell us about your practice and kind of what it looks like, and then we'll kind of drill down on the actual topic.
Absolutely. So interventional cardiologist, as you mentioned, all of my training was done here in Chicagoland area. So I practiced in northwest Indiana, which is a stone throw from Chicago. Did my interventional cardiology and general cardiology training at University of Illinois, Chicago. Got my hands dirty there doing the robust practice of interventional cardiology, coronary, and mostly peripheral as well. I'm not a structural trained guy, so my practice focus has been on managing complex coronary disease, cardiogenic shock, and also critical limb ischemia as we've come to treat it in the local area.
Nice. How long have you been out? If you don't mind me asking, Dean.
No. We got to be honest, right? So finished training July 2012. So we're coming on 12 years of practice.
Nice.
That's
very
it.
Nice. So like your first job at a fellowship, it was at this practice that you're at now, and hospital-based, lab-based, private practice-based?
No, my first job, this is my second job, and both positions have been a hospital medical group employed. First one was with a large employer in the area, Advocate Medical Group. Was really fortunate to take on a job right where I trained. A lot of my training was at Christ Medical Center on the south side, southwest suburbs of Chicagoland, and was very fortunate to get on staff there, join a practice there, and then just got a phone call one day from a buddy of mine that I trained with, and he said, hey, we have a good opportunity just across the border, and it was an extra 10 minutes in the car, so why not? Took a look at it, liked it, and been very happy there as well. So I've been at the Community Care Network in Northwest Indiana for the last 5 years now.
Very nice. All right, so let's jump into it. So acute limb ischemia, or ALI, it's a broad topic, but we're going to kind of narrow it down. But if you would, Dean, will you kind of just go over like for your practice specifically, like a typical patient presentation and how you get alerted, and then we'll jump into workup.
Absolutely. So most of our patients come through the emergency department. We are kind of the first call as interventional cardiologists at our hospital, and I know that's unique, but a lot of hospitals operate differently. We do have good surgical backup, so it's the usual patient presentation is somebody that comes in through the ER with symptomatic leg pain, and the ER physician will typically contact both myself or one of the interventional cardiologists on call for the group and one of our cardiovascular surgeons. So we approach it as a vascular care model. The two of us will usually then talk, develop a workup plan and a management strategy from there. But the majority of these cases are coming to us through the ER.
Okay. Once you've been alerted, does the ER kind of have a standard workup? Like what's typically been done, and then what needs to get done for you guys to kind of get a care plan up and ready to go?
Well, since we do these cases, if it's going to come to the interventional cardiologist, since we do these cases in the cath lab, we of course have a cath lab team on standby for all sorts of call. But a lot of the workup is done, from the ER doctor, just getting usually a CT angiogram from the get-go. If there's some renal insufficiency and we have the, labs back pretty quickly, we might opt for a stat arterial duplex. We have the capability of doing both, so we kind of just manage that on a case-by-case basis. One patient might have good kidneys and we have no problem getting a CT scan, which is a little bit more fruitful. Others, we have the concerns about renal insufficiency. We know there's a good chance they're going to go to the cath lab, so we'll try to favor an arterial duplex first if we can get that. And if it's really somebody that's, unstable that has to go sooner than later, we don't really delay, but we do want that first piece of data to know what our approach will be like.
Okay. If you have a preference and just say the ER doc or however they present, maybe it ends up in your clinic somehow. If you could just start out and have anything, what would be your workup? And I guess what I'm trying to get at is why do you like CTA or duplex over one or the other?
I mean, I think it's just a matter of really deciding where your level of disease is. Where's your level of obstruction? I mean, we can figure a lot out on clinical exam, of course, but if you have femoral pulses or if you don't, if you have popliteal pulses or if you don't, but we all know that these are complex patients presenting with a complex disease state, and so if we have the luxury of time of getting a CT, it's generally preferred because then from the get-go we know where our highest degree of obstruction is, where our access is going to potentially be, what the aortic bifurcation might look like if we have to come up and over. Certainly, if we are dealing with a heavily calcified vascular structure, we can get all that information pretty quickly.
Gotcha. If I could back up and just talk about H&P, I know that some of this legwork has already been done, but just for our trainees out there, can you kind of talk about what a focused H&P would look like for a patient like this or a vasculopath? Like, what are some of the things that, maybe some of this changes what you're going to do, or maybe some of it's going to change the care on the back end, but just kind of the basics of what you're looking for with your H&P.
Yeah, absolutely. So, in general, you want to know vascular disease risk factors. I think that goes without saying. So you're going to try to ascertain a history of diabetes, a history of dyslipidemia, any kind of high-risk history, such as, prior coronary event, prior stroke, any prior vascular interventions that have been done, whether or not they're actively smoking, I think is still a big deal because it's a big point of education, right? We don't want to miss an opportunity to say, you're in bad shape because you're smoking. Let's try to modify this. But then for me, and I think for, many of this audience, we also want to know what's been done. What kind of procedures, if any, have been done to this vascular patient in the past, be it endovascular or open surgical, because it obviously changes completely how we assess, access, manage that patient.
Exactly. All right. We're kind of past the H&P. We're past the workup. Oh, I guess I should back up and say any lab work that's mission critical that maybe hasn't been ordered. And we kind of mentioned a GFR, creatinine, anything else that you'd like to know?
I like a lactate level. I think it gives you a lot of information to just get a sense of how acidotic this patient might be from an ALI event and the degree of ischemia. The degree of lysis here, comes into play. A CK as well is usually in my order set, but in general, I favor, first knowing what's my hemoglobin, what's my creatinine, what are my platelets looking like, and, how acidotic is this patient? It's kind of a marker of how sick are they, right? So
sure.
To me, it's an important lab.
Okay. After that, so we have some different ways to treat these patients, and I'll kind of lay them out, and then, we'll drill down on endovascular approach. But there's conservative management, endovascular, and then maybe surgical. And I know that we're talking to a lot of different doctors, and maybe not all of these are available at different hospitals, depending on availability or, doctor availability or cath lab availability. But can you kind of just talk in very, very broad strokes about the different ways that you might manage one of these patients?
Sure. I think, the first piece of information is, how threatened is the limb? and what's the degree, or rather I should say, what's the level of threat. So somebody that is, presenting with the classic, pain, pallor, pulselessness, really more about looking leg where they can't move, can't feel. I mean, that is somebody that is extraordinarily high risk. And from there, it's time of onset. I mean, if they've been, sitting at home all night, waiting around for this to maybe get better and they didn't, and then they finally can't take it and it's been over that 4-hour mark a little later, we know that there's a higher degree of muscle loss at that point, and our options from an endovascular perspective, in my opinion, can be a little bit more limited, only because that even if you're able to extirpate the clot or whatever the issue might be, you still might be looking at somebody who has a more mobile leg that might need to go to the operating room for fasciotomies or something more definitively surgically. In the case of those who are threatened viable but still have some motor function, those patients, you've at least know that you're in a position to, if work earnestly and quickly, that you can really reverse that process a little faster. And so those are the ones that we like to jump on a little bit faster and get into treatment after looking at their scans or trying to decide what to do in an angiogram suite. Then we can at least decide as a vascular care team, is this going to be a primary endo approach or a primary surgical approach?
So that's actually kind of what I get into the heart of. And kind of what I'm hearing is that like a lot of it's like driven by acuity and like what the limb looks like. But do you kind of work with like your vascular surgery colleagues to determine like kind of who takes the lead? And are there any, like, do any of the vascular surgeons have like a surgical or endovascular option that maybe for some reason, like while you're doing the workup, you're like, oh, this is a better fit for you guys than it is like interventional cardiology? Do you know what I mean?
Yeah, I mean, it's a great question. And I think it comes to the thrust of who owns the patient is somewhat system specific. I mean, at our institution, we have great open surgeons. They don't do anything endovascular except for AAAs. So, for the most part, they're going to defer anything endo to us. And other institutions, you might have vascular surgeons on site that are going to be able to do both themselves. You might have just the primary IR team. That's the first call. In our institution, it's interventional cardiology. So very institution specific. And I think that's why we try to both engage, from the get-go and say, look, let's just talk about this. Let's collaborate, because, the last thing we want is any kind of so to speak, turf battle on this. I mean, we really want a collaborative approach. And so with my institution, Community Hospital in Munster, Indiana, we're very fortunate to have that combined approach. We have good dialogue from the get-go. And then it's not uncommon for our surgeons to come walking into the cath lab as I'm taking pictures, and then we collaborate and discuss, what do we want to do next? So that's, I guess that's where the rubber meets the road on that one, Chris.
So say ER calls you 2 a.m. And you have a cold leg, and I guess now what I'm trying to get to the heart of, without like creating like every possible patient scenario, is how quickly are you guys getting in gear to take these patients back if they are appropriate for like endovascular treatment? Is it like STEMI situation where it's like, let's get everyone in as quickly as possible? Or are there some conservative things that you can do while you're kind of like treading a little bit of water until like everyone gets there for daytime work?
Awesome. So great question, right? I mean, I think, the level of acuity dictates when we hop on it. So our group of interventionalists, I mean, we treat it like a STEMI. So if we do have, so to speak, the cold leg, the proverbial cold leg with the classic Ps, I mean, those are the patients that we're activating the lab, we're coming in at night. I'm typically speaking to, my surgical colleague on the way in and just saying, hey, I'm going to shoot some pictures, then I'll give you a call, that sort of thing. And yes, we don't wait till the morning on those. If we have, more of like a 2A little threatened viable limb, but the patient is relatively comfortable and we know that there's still some good motor function, maybe they just have some paresthesias and there's a little bit more of a softer presentation, that's where it's going to be a conversation with the ER doc, whoever the referring doc is, nursing staff, keeping an eye on everything, looking at labs, anticoagulating that patient, and then perhaps they'll go in the morning. But they have to not be at such high risk for limb loss, if that makes sense.
As far as anticoagulation for patients who, before they've been taken back to the cath lab, do you have any like tips that you can offer as far as conservative treatment, like just for that time in between notification, workup's getting done, but before they've gone to the cath lab?
Not much. I mean, we're a heparin-based lab, so we're going to mostly You just start a heparin-based protocol from the ER. Yep.
So let's get into like the meat of it, like the procedure part. Anesthesia-wise, patients, I would assume either local or moderate sedation.
Yeah, correct. And that's a hot button issue. I mean, every once in a while, you can get into a scenario where the patient's in so much discomfort that we're calling for anesthesia support and at night, and we've done that. I mean, there's a lot of these cases that we can start to work on with typical moderate sedation, but if they're really mobile on the table, there's a risk of bleeding. I mean, as you know, with the types of drugs we're going to be using and the risk of bleeding inherently from any endovascular procedure, we need that patient to be stable and comfortable. So if we can't get them comfortable, we can call our anesthesia support. If we can get them relaxed enough with moderate sedation, that's how we prefer to work.
So after that, I know it's tough to know. So you can create whatever patient is kind of easier to kind of get the point across. But I was thinking room setup. And basically I want to know is it like if you're treating left leg, or are you think it's better to go up and over or antegrade, and a bit about room setup and like access site?
I think most of these cases are contralateral. If I look at a CT scan and it's a tough bifurcation and I have distal thrombus or distal occlusion, then we might opt to go antegrade. But the road has to be clear, right? So if the road is unknown, contralateral is our typical friend. So let's say it's a left, iliac or femoral occlusion, we're going to be accessing right, and we're going to take our initial angiograms from the distal aorta to make sure there's nothing there that's concerning, paying attention to our interventional exam, as I call it. How's my wire field going up? Is there any signs of anything else blocking the road? And then proceed with our intervention, typically contralaterally. I would say our routine access would be 5 French until we get up, get some pictures, get the lay of the land, and then decide what we want to do next.
So your first picture, you said you shoot from the distal aorta. I see some people who will do like an abdominal aortogram, and they actually like include like the mesenteric arterial vasculature. But if you don't have any reason to suspect that there's clot like in the renals or the SMA or IMA, you just distal aorta shoot, and basically you're looking for a runoff.
Generally, yes.
Okay.
Yes.
Got it. So I really like what you said, and I'll go back to it. The interventional exam. So like how the wire feels going up and over.
Totally.
All right. So I do want to get into that when we're talking about crossing clot. So you've shot your picture. So it's right groin access. You've shot your pictures from the distal aorta. You have an occlusion. You can either pick iliac or femoral. What next?
Well, I think we determine where's our collateral bed, if any. Hopefully there is some collateral bed. It increases chance of limb salvage there. If we have a flush occlusion, obviously looking for the classic meniscus sign, we can engage it as clot, appreciate it as likely clot. Sometimes we're fooled. These patients come in and you think there's just clot there, and obviously there's a lot more work to be done crossing through a subacute thrombotic leg, or something that is definitely a little bit more chronic and calcified. In general, we're assessing proximally and distally, trying to determine where our reconstitution zones are and making that our target to get that patient out of trouble. And so, once we identify where our targets are, the question is always then, is this a better endo case, or is this a better case where we should be considering a surgical intervention early on? And that is, typically something that we'll just discuss. If my surgeon's up there, I might say, hey, SFA looks like it's out. I've got some reconstitution of the tibials. It looks pretty soft. I think I could try to cross it and then make my next decision as far as treatment modality. Or, I don't see much. I don't know where my best reaccess point would be, reconstitution zone would be, in which case we have a lower threshold for a little bit more exploration, perhaps surgically, if it looks like that limb is very, very threatened. But I think the majority of our cases, we can find a zone to get to and try to manage it endovascularly.
So if you decide that the patient is like an endovascular candidate, at this point you have like a diagnostic catheter in, maybe you're up and over with an in-hole, but you have a 5 French in the contralateral groin. What is, I guess, like, what are the next steps? And there's so much like I want to ask at this point, but let's just, what's your next step?
To me, it matters on where the level of occlusion is and, so to speak, how much thrombus I think is there. The cases that really worry me are, if you just have complete tibials out and you don't know what to get into distally, the question is this somebody that should maybe have, and I'm going to back up to what I said when I don't see a good distal reconstitution zone, is this somebody that you should potentially have, fugative balloons exploring the tibials in the OR? Because if you can't find a distal reconstitution zone that you will get back through and through and create a channel of flow. Sorry about that. So if you cannot find a channel of flow to reconnect to, then I think your interventional techniques from an endovascular perspective can be limited. Now, if I see a large clot burden in a large iliac artery, there's always concerns about, am I going to get enough out or am I going to shower? I've personally had success using thrombolytic catheters in those cases. I'm sure many of us have. And, you certainly can also consider a femoral exploration and a retrograde approach with a surgeon in the OR. So you just got to be honest. I will typically try to cross those. So getting back, I'll change out my 5 French system to 6 or 7, whatever I think I need, and then proceed. If I think it's primarily going to be a lytics case, Chris, then I generally would like to just try to cross and keep everything 6 French, just minimize my footprint. And if it's something that I need a little bit more robust device or do something mechanical, then we'll aim for 7. And that's the general start. If it's a smaller vessel series, then I can still choose a different device based upon what I think.
Okay. So let me just stick with large vessel, fairly large clot burden, but are appropriate for lytics. You cross. Can you give the audience and members any kind of sense of when you are crossing what you hope is clot, what you hope that your wire does, or kind of what you're looking for with the wire? What does your interventional exam look like? What are you trying to ascertain with that?
Yeah, I love the term. So, it's the feel of the wire. I don't want to have to use very aggressive wires and loop them and push with a lot of pressure, right? If this is relatively fresh thrombus, the acuity of that clot should allow me to cross it very easily with a wire. And so I generally like, my workhorse would be a soft glide, just because I feel like I have good feedback with that. It might not be enough. You might need a stiff angle glide, or you might some might prefer more of a woolly. But for me, glide gets through clot better. I generally would keep my profile 035 if I'm working in the iliacs anyway. So a soft glide with a contralateral sheath, kind of just perched in the iliac if I can, in the common iliac, that is, and then just try to cross with a 035 wire and catheter. Take your pick, right? CXI or a Trailblazer, and try to make my way through and through. If you don't have a good purchase spot for your crossover sheath, changes the game a little bit, right? You don't know exactly where your ostium takeoff is, or even if you do, are you gonna have enough support to get through that? But assuming you can with a soft-bodied wire, then you have treatment options available for fresh thrombus there, and that's where I would probably favor a lytic case, I think.
So if it ends up being a lytic case, how much do you do on the table, and how much do you just reserve for, or actually you can just kind of tell us, if you can, Dean, what you like for lytics, where you send them, and then kind of what your protocol looks like if you're just going to drip. Right.
So we drip and we ship to the ICU. I mean, I think that's what most of us do. Follow our fibrinogen levels, follow our hemoglobin trends. Usually we'll give up to 5 milligrams of TPA bolus. I typically will use an ECOS catheter. And if they're very tortuous in their iliacs and it's hard to get that intercourse dialet from an ECOS, then I might just use a Craig Mack. I think in those situations, a couple milligrams of TPA up to 5 on the table is reasonable, and then run them at 0.5 to 1 per hour, depending upon how much clot you think there is, and just reassess quickly. Just make sure you're on top of that patient, following their levels and making sure there's no signs of bleeding. But as long as I can keep my footprint 6 French, I think that that makes me happier putting a lytic catheter up and over, because I'm minimizing the contralateral bleeding.
Yeah. If you are dripping with TPA, concurrent heparin?
Yeah, why not? Most of the time I'll just use fixed dose. Just give all the good humors, get some of those procoagulant effects away. But typically just a fixed dose, somewhere 400 to 600 usually works for me, kind of half of what I might do.
All right, so say that lower clot burden, more distal vessel, and you can take your pick, but also a candidate for endovascular therapy. But so what are some of your other options for thrombectomy?
Yeah. So depending upon vessel size here, I really think that, new technology on the market that's great is some of the stuff that is both mechanical and aspirational, right? So Penumbra's been around for a while. There's some good aspiration devices there. I've certainly done some, realistic cases with AngioJets in the past, but my go-to at this point has been the Pounce device from Surmodics. I think that it is a very capable device. I would be a little hesitant using it in an iliac if it's larger than the footprint of that catheter itself. Same thing with like a Penumbra lightning system. If you're really looking at a bigger vessel, I want to be able to make sure I get some good wall apposition with the catheter itself so that I can, then you really extubate clot more efficiently. So that's where, you might choose one versus the other. I think depending upon your nature and what you like to do and or how old you think the clot is, I think you can make good inroads either way.
The Pounce, how big? I'm sure it's got an IFU, but what's like vessel size that it can go up to? Or actually both min and max.
Well, so off-label min,
we live off-label.
We live off-label. I'm more afraid of a lack of capture. So the Pounce device, I think, works, really, really well. I would use it in a common femoral artery just slightly above the size of the device. Their product line has now an LP, which is, I think, goes down to 2 millimeters in size, 2 to 4, if I'm correct. And then there's also the original device, which is down to 3.5 millimeters. So 3.5 to 6. So I've had some success with it, working through the common femoral. So I have some colleagues of mine. And so I will really favor it in that site. If you're looking at a bigger iliac that's 9 or so, I worry that I'm just not going to really capture thrombus efficiently. Working down in an SFA and into the tibials is usually no sweat. So I have taken the original device off label, of course, down to around a 3 millimeter, TP trunk or 3.5 millimeter TP. Well, I guess 3.5 would be on label. So 3.5 millimeter TP trunk, and I've had really good results. What I love about it is that you have the ability to typically treat multiple sections with one device as well. So you have a mechanical device that has the ability to really oppose, anything within that size range. So you don't feel like you have to switch out for a smaller catheter to get lower if need be, if that makes sense.
Well, so I'd only I've never actually put my hands on the Pounce, but if you could, would you just say for the audience members who've never heard of it and don't know anything about it, can you just give a brief description of what that catheter looks like? And also is there anything also you need on the back end? Is it also an aspiration component that hooks up to a canister or anything, or is it's all you pull it into that funnel?
Yeah, so there's no aspiration component. I will say on the back end, what really makes a difference is your sheath. So I favor the Truva destination sheath in these cases because they have that so you can pop off the your end port, which makes a difference because as you're pulling thrombus through your sheath, you could just pop that off the back. So I think that's the biggest BackTable work there. It comes with a catheter that's an 035 lumen catheter. The working platform of the wire is approximately 035 as well. And so looking at the product outside the body, you have kind of 3 main components. You have the nitinol baskets that are mounted on the wire, and you have the what we call the funnel, which is almost looks like the sheath we see from an ARI, where it has that funnel output ready to trap stuff. And then finally you have the 035 catheter that it comes with it. Your steps are, to cross your lesion like you normally would, get to your zone of reconstitution with an 035 catheter and wire. At some point, you can exchange out either for the Pounce catheter. I have been able to deliver the nitinol baskets of this device through a Trailblazer just fine. 035 Trailblazer, that is. Switch out those catheters, leaving just the basket behind. And then you bring in the funnel, and the funnel is then brought down over the basket wire because the baskets are mounted on the wire. Leave it just where you'd want to protect, proximal to where your thrombus is, and then just pull slowly into your baskets until you get to the point that the baskets themselves are completely within that funnel, and then you just take it out as one unit. There's a little locking feature on the back. Take it out and rinse and repeat, so to speak.
So you can just keep using the same Pounce device over and over. If you need to make 3 passes, or if you need to take it into a different vessel, it's all the same device. As soon as you change it up. You're
gonna take it out of the body, and you're going to re-prep it, and then you're just gonna put it back in. You do have to recross, right? So that is That is, kind of the one thing to remember. Wherever you start working, you have to get back to that spot. Now, the one thing I failed to mention, by the way, is this is a 7 French device. So when you switch for your Terumo destination sheath, preferred, my preference that is, you have that sheath back in position. And if you are in a setting where you feel that you don't want to give up wire position, I have done cases where I'll leave a 014 wire down.
Yeah, like a buddy wire.
Like a buddy wire. This is off-label use, of course, because you have to be using on-label with the funnel. But if you can, let's say for example, you have a thrombus and an SFA that is in the mid portion, and you're worried about recrossing because it was a little difficult to get through the first time. So, your options are, of course, make a small channel with a balloon, or you leave something downstream. So I would typically, in that case, choose a spider, just so I have embolic protection, a spider filter wire, leave that distal, and now just bring in my 035 catheter through my 7 French sheath with the baskets, cross, and then pull back with the sheath a little bit more deep-seated. And I just do that so that I don't pull thrombus back into zones I don't want it to be in. And then from there, you can just, flush your sheath out really well and then go back in and usually a pass or so. And you're going to be using the device completely with the funnel baskets and the funnel and baskets. But fresh thrombus is not an issue. It's more of these subacutes that you're crossing that you're a little worried about a channel.
Okay, fair. Thinking about like tips, also I should ask, is there, in your practice, and we're only talking about your practice, do you like any of the aspiration devices? I was thinking like Penumbra, AngioJet.
Yeah, so I used to be a pretty big AngioJet guy. To be honest, I mean, it's a matter of I changed hospital systems and they didn't support much AngioJet. So I don't like to be a one-trick pony. I like to make sure that I'm comfortable with a couple different technologies just because. I mean, I think I've worked at a total of 6 different hospitals at this point, between 2 jobs. So, labs are going to staff things differently, and they're going to stock things differently. So I've become a little chameleon. With that said, I've certainly had good success with, the AngioJet line in the past. But, more recently, it's been, if I'm using aspiration technologies, it's Penumbra. And, the Penumbra system has been fine for some cases as well. But, I think it all depends on your goals of what you're trying to achieve with that thrombectomy case.
Is IVUS a part of the practice?
Huge. I mean, the decision in the case is basically made in my book by IVUS. If you're, I don't want to use the term efficient, but if you're a pretty regular IVUS user and you're, comfortable with looking at different morphologies, I find that anything that looks a little bit more subacute, more wall adherent, I mean, I want to go mechanical all day long because I think that having a basket that's going to oppose that vessel wall is going to really extirpate clot much better than if I'm trying something aspiration. And I think that's where differences come into play as far as what device you use and when. Because in my book, if it's fresh thrombus, there's a lot of tools that'll work, right? We can drip, we can aspirate, we can pull, we can do a lot of different things.
Yeah, a lot of roads to success.
A lot of roads, right? A lot of roads to Rome. But when you have a scenario where there is certainly some subacute disease state that you're trying to manage in a patient, and maybe this isn't an ALI patient, Chris, maybe this is somebody with a little bit more, critical limb ischemia, but had a recent closure, and I can give you an example of that as well. But in those situations, I find that IVUS helps not only determine where I am as far as did I cross subintimally or not, but, where's the area that I have to be mindful of for wall adherent thrombus or wall adherent gunk, whatever we're trying to get out.
Very nice. As far as the actual procedure goes, without like drilling down too far, like on any single device, is there anything like I kind of left out? I do have a couple more questions about procedure, but anything that I left out as far as like device specific questions, like things that you like to consider that may shift you one way or the other, or we kind of already did talk about like when you may like shift towards mechanical thrombectomy, maybe you have something subacute, but is there anything else I skipped?
Not really. I mean, I think the biggest decision tree points are the acuity is probably number 1. 2 is size, reference size of the vessel. Am I on label? Am I not, with any device here? And am I going to get efficient thrombectomy? And then I think the third is what are the side branches that I need to protect? And how does that come into play with the procedure?
So my 2 last questions for the actual procedure are collaterals, like the location of clot, and then what you have to be considering like whenever you're actually doing your thrombectomy. And the other is like kind of endpoint. But can you talk a little bit about what you're considering as far as when you're treating and like your collateral flow, either upstream or downstream?
Clarify that. I mean, in terms of collateral flow that I'm trying to protect, or
yeah, that's kind of what I'm getting at. Is like so you have a clot in a certain location. What are you considering like when you're treating to not jeopardize like those other branches that are nearby that are that's your collateral flow?
Sure. So I think with different techniques, you might approach things differently, but let's stick to mechanical. So what I like with this mechanical system is the funnel. Well, there's reasons I like it, but the funnel itself, I think, is my little safety net. So, you can park that just distal to that collateral you're trying to protect. You can park it into, let's say, a below the knee branch, and then you're just directing your thrombectomy into that one target zone and then protecting these side branches so that you don't jeopardize them. So I think, that is a factor that would weigh more into me choosing this mechanical device. I'm sure there's plenty in the audience that'll disagree and say, hey, I do a great job with aspiration, being mindful of collaterals. And that's probably operator use dependent, and that's fine. But if you have one technique that works for you, I guess stick with it. But I like this option.
And the other thing I was going to get at is, as far as like treating clot proximal to distal.
That's a great question. I think if you're really using this technology, the mechanical technology, and even now with aspiration, I think I've always been of the mindset of starting more proximal and working distally, which, I think in the interventional cardiology training was always you start distal and work prox. This is a situation where, I want to use that obstructed outflow, kind of as my safeguard as I debulk what's ahead of me. And I don't want to just plow through, that street and then just try to, deal with the aftermath of things showering. I want to just start proximally, debulk thrombus, take another interval picture, try to decide, run your IVUS down again, see where your level of, open vascular structure is now, and then just keep working. So prox to distal. So
my next line of questioning is kind of along like endpoint. Like when are you done with the case? Assuming, so I have a lot of questions about this, but like I'll just start you off, like lay it like an open-ended question. Like, when are you done? What's your endpoint?
Great question. So inline flow to my foot is the first place of being done. It's always hard when you're looking at somebody's leg and you're thinking, well, there's probably 3 open tibials now and I only have one good one or 2. But, I think, as long as I have a good major vessel to the foot and, let's say they have a pedal loop that's intact, then, I'm going to get that person out of trouble and I should be okay being done, provided I've, debulked enough debulked enough thrombus to have inline flow. I don't necessarily use IVUS to determine what I'm completely done, but I might use it to determine one trouble segment and when that's clear. So, those are, techniques and tools that we might vary with. But I think it's judging the degree of outflow to that foot and making sure that it's sufficient to heal. That's when I'm done.
So if you do have inline flow, so say it's a single session treatment, you had a decent clot burden, but you feel like you removed a good bit, and maybe there's some small pieces that got showered a little bit, but they're non-flow limiting. Is the situation, if you have what you kind of believe to be good inline flow, that everything comes out and you close, or do you ever have a situation where you bring that patient back either later the day or next day for a repeat angio to see if there's anything to tune up?
Depends on what the situation is. So, for instance, I just had a case where it was actually an occluded GSV in situ graft, and it was to, one single outflow AT. My partner actually started that case first, used thrombolytics throughout the graft, and then got good flow into the AT. But the concern was we needed this graft to stay open, right? So with one single outflow vessel, knowing that the patient previously had a good tibial system, we brought the patient back for a relook angio with the goal to go ahead and treat the TB trunk. TB trunk had some thrombus in it. Actually treated that with a Pounce LP, got some subacute looking stuff out, got back through the TB trunk and helped the outflow to that system. So those are going to be the cases where, you're going to, be questioning, do I have enough? And that particular patient was admittedly not ALI, it was CLI, and the patient had a wound. So I need to promote wound healing there. The cases that we do one index treatment, be it, mechanical or aspiration, and you think you've got good flow, I'm not done with antithrombotic treatment at that point. I mean, those patients are they're going to go back on heparin, and then we'll just reassess and then decide, is it, do they need repeat imaging? And if so, CT, or should we bring them back and take a look? It depends.
Fair. So procedures done, let's just say you close, you think you get a good result, good inline flow. Do all these patients, just like a question, kind of long post-op care, did they all end up in the ICU or a step-down unit or even floor? That's
a great question. So the one thing I think that's nice about not using lytics is I can avoid an ICU stay, provided I have a good salvageable result. I mean, salvageable foot as a result. So if the patient is feeling better, they're moving, and I can just keep them on some anticoagulants and then put them in a step-down unit, awesome, right? Avoided an ICU stay, got the patient out of trouble, potentially decreased the hospital stay. I've had success with that in some AFib embolization cases that were fresh thrombus without much residual disease. So you get through, you take care of the thrombus, and then you go ahead and just park them in the step-down unit because you had a nice result with your mechanical thrombectomy. Those that certainly have a lot of clot burden, we know they're going to go probably to an ICU with a lytic catheter in. The majority of these patients, provided they're stable, you're going to close, you're going to keep them on anticoagulation, and you're going to get them up as soon as you feel that they can, and then just keep them moving and hopefully decrease that hospital stay.
As far as follow-up goes, so once they're uneventful hospital stay, they're out the door, they follow up with sometimes hematology, vascular surgery. Like, what does the follow-up care look like for these guys?
Yeah, so it depends on, what the issues we do. I love that you mentioned hematology. I'm pretty quick to get a hematologist involved in a thrombus case. I just think it's good routine care. They may or may not offer, a new diagnosis that needs to be treated, but in the least you have another good head in the case. Usually our vascular or surgical crew will follow the patient in-house, and depending upon the result and what else needs to be done, if it's a pretty straightforward, hey, this was an embolism case, it's clear, the roads are open, we've got good runoff, they probably shouldn't have any more issues, they might just sign off and not follow the patient again in the hospital. Then I'll see them and help manage them. If they have residual disease and there's a chance that they're going to still need further interventions, they're routinely seen then by myself and one of our cardiovascular surgical colleagues.
If you had to ballpark, like, how many of these patients end up, like patients with acute limb ischemia end up like in the care, like as kind of in like the vascular path care paradigm, like what ballpark of patients end up like kind of seeing you repeatedly and end up needing procedures for, like, say, CLI or even coronary or anything like that, like just the vascular paths who like end up being repeat customers?
Yeah, it's going to depend on the presentation, right? But if it's an AFib embolization, they pretty much routinely are going to follow up with me because I'll provide the cardiac care as well. Those that are primary vascular cases or have significant CAD, I'm still going to follow them and manage the risk factors. So I would say that a large part of these patients, at least a third or more, are going to continue on with me.
So taking a little bit of a left turn, just wanted to talk about complications. So I like to divide it up into two groups. Like, can you talk about the most common complications that you see with this? And then I want to talk about this is like the absolute worst complication. This is like exactly what I'm trying to avoid with every step of my procedure.
I love talking about complications. So
yeah, right. That's like everyone's favorite.
When you're at a meeting and there's complication talk, like that's the packed house, right?
Yeah, that's right.
So, I mean, if we're speaking about complications from any thrombectomy case, I mean, certainly the biggest is going to be bleeding. I mean, I think anytime you're managing a patient on multiple blood thinners and you're putting catheters in arteries, I mean, there's a risk of bleeding, no doubt about it. And those are the ones that we fear. Because patients can get really debilitated from a couple bleeding events. So that is kind of always in my background, in my brain as something I need to be the most mindful of. But technical mediated complications. I mean, fortunately, with the if we're speaking just about this mechanical device, I haven't had any that I would write down on the board and say this is a terrible complication. But I think anytime you're working on a vessel structure, you're obviously at risk for the classic, dissection causing a worse flow, or simply just, pushing things downstream and worsening that embolic debris. I find that, without disrupting a large clot burden and just, starting slowly and working, you can minimize, working proximal distal, I think you can minimize that embolic risk. And I think that goes with, aspiration techniques as well. So I think that's always a concern. And so as long as you work, steadily in that methodology, I think things can go pretty smooth. The other, I'll call it a complication, but it's really more of a miss was, where was your clinical insight in this case? If you have a patient that you think should have had or was a candidate for an endovascular technique, but you're not following them closely, and they develop a compartment syndrome, that would be a problem, right? So that would be something that you really have to not ever miss. So these patients, no matter what you do, I think you have to, not walk out of the cath lab and or IR suite and be like, that's it, we're done, yay, right? You have to, round on those patients, for the next, that day a couple of times, and then later on the next couple of days, just to ensure that, that they're recovering. And, if you miss a failed recovery because of, some sort of increased pain, compartment type syndrome, you've really done that patient a disservice because you brought them to a state of betterment, and then you didn't complete the care. So that's, those are the things I worry about, and those are the things I look for the most. And I think that's also why, we have our surgeons following too, because if those sorts of things develop, they're on hand to manage it. Yeah.
Well said. So we're coming up at the hour. I want to ask, any good articles that you've come across, like if someone wanted to get into this, or say like they just joined a cardiology practice like yours, and they're like, oh man, I've never had to do any limbs. I've always been doing like coronary work, and now you guys are throwing me into this, like, the cold like cold pull. Like, can you give anyone some advice on just here's some helpful papers that like can kind of get you started and point you in the right direction? Like, and also think about it from like, leg. Yeah, and also like think about it from like the trainee standpoint, like anything that you like.
I thought you were going to say cold leg club. I thought you were going to go there. It's like, I don't like that club.
Sure.
I don't have any particular articles that stand. I mean, there's always EVT supplements on different technologies, and you can read about success stories of cases. And, you can obviously read back some classic articles on just, thrombus development. I think it's good to read about, thrombus development, understand, fiber deposition, when that starts to occur, get a better understanding of the fact that, not all clot is the same, that you're going to have, different, fiber and polymer sizes that make certain things, tougher to treat. It's not anything you're going to diagnose in the cath lab, but just it helps your understanding of knowing where you are in that process, so that when you're faced with a patient presentation, you can try to think, where are we? Are we early in this clotting process where we have a limb ischemia that's been a little bit more subacute, or are we really early, or are we late? And that will help make your decision. If you're really late and you feel that it's a better bypass candidate, good. Make that decision and talk to your surgical colleagues about it. But I think the biggest thing is just, find a friend and phone a friend. I mean, I came out of my interventional cardiology training still calling colleagues that and I'm sure you did when you came in the IR world.
Absolutely. Absolutely.
That helps you. And, those mentors still stick with me. I'm friends with them and I continue to talk and share cases routinely. And so, having that dialogue and not being all about yourself and having the bravado of I can handle this, but understanding that you're going to be continuing to learn in this patient population for some time, and managing those patients efficiently means, having a contingent of people to work with, bounce cases off of, and make better decisions based upon, common thought, because you're not going to see every scenario right out the gate, especially for the trainees.
Of course. Well said. So, Dean, final thoughts? Any stone left unturned that I didn't bring up that is a gaping hole in the talk here?
No, I think you did a great job.
Oh, thank you, Dean. All right, appreciate it.
I hope everybody just finds it helpful.
I'm sure that they will. Thanks for coming on.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manveer Singh Sabri.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.